I would love to bring.
This meeting is being recorded.
Great. So before we start this meeting or this forum, I would love to introduce our CEO here at the YWCA of Central Massachusetts, Miss Deborah Hall.
Thank you, Gemma. And I am so excited to have everyone here today for what promises to be a wonderfully informative forum. We are also happy to invite you to join us for this forum on the last day of what is formally recognized as Black History Month in America. And the theme for Black History Month this year is Black Health and Wellness. So this is a most appropriate topic, although at the same time discouraging and challenging topic. But I am hopeful that our speakers today will shed some light on what's going on in terms of Black maternal health and infant mortality, and we can move forward and do what our mission mandates us to do: eliminate racism and empower women. So welcome everyone, and I can't wait to get started. Thanks, Gemma.
Thank you, Deb. So Deb just alluded to our mission, and I want to recite that for those who are just joining us. Our mission here at the YWCA is to eliminate racism, empower women, promote peace, justice, freedom, and dignity for all. Why, you may be thinking to yourselves, why is it that we have called this call to action on maternal and infant among Black women? And I want to narrate this story. So maternal death among Black women is still three times the rate for white women. In 2020, the maternal deaths for Black women was 5.3 deaths per 100,000 live births. In Massachusetts, Black women are 3 to 4 times more likely than white women to experience maternal mortality and morbidity. And Latin women are 2 times more likely. For Black women in particular, morbidity, it's 3 to 4 times higher in the state of Massachusetts. Looking more locally here in Worcester, maternal deaths are 17.14 per 100,000 live births. And for infant mortality here in Worcester, it's 14.6, looking at 2016 to 2018 data. On the other hand, when you look at the numbers for infant mortality in the nation as a whole, you do see a decrease, but still both our maternal and infant mortality death rates in the US is still higher than other developed countries in the nation. And what's often been being cited as some of the causes of barriers looks at social economic inequalities, and some of these inequalities, especially for our Massachusetts, our state, or even locally, shows that Black women are more likely to cite issues about their respective health. And as a definition for respective health, that includes like listening to women about their experiences and what they're feeling when they are in the process of childbearing. There are also barriers that may differ between in the way how healthcare providers may relate to patients, Black women especially, due to following protocols that may prevent individualized care among Black women. And so these are some of the reasons why we've held this call to action. And just as a notice, this will be a 1-hour forum, and we have about 4 panelists here. 3 of them are going to be presenting to us. 1 is going to join our Q&A session. Everybody will have about 10 to 15 minutes to present, and we're going to be watching time. And at the end, we will enter into our Q&A session. That's going to be, depending on the time, that's going to be about 10 minutes, and we will just get one question. We may get 1 question from the audience, but we do have 3 here already prepared. And I do want to mention that this presentation is also being recorded. So if you do not want to be seen, or if you do not want to, be involved, I guess you can edit yourselves or watch the presentation once it's done. But we do hope that you do join us and share this information with your friends and colleagues and folks who may be in need of this information here today. And without further ado, I would love to introduce our panelists. And the order of our event today is Dr. Shields, so Sara Shields. So Sara, a little background about Sara is that she's a family physician and she has worked at Family Health Center in Worcester since 1995, practicing and teaching full spectrum family medicine, including maternal care to family medicine residents, while she also is serving as a director for inpatient prenatal services for the UMass Department of Family Medicine and Community Health since 2017. She's co-author with Dr. Lucy Candip of Women's Centered Care in Pregnancy and Childbirth, which uses the lens of evidence-based patient-centered clinical method to reframe thinking of how many of the recent challenges in maternal care are still prevalent. She remains active in the community service and advocacy and advocates about maternal and infant health through her work as the chair of the Worcester Healthy Baby Collaborative and also the chair of the Massachusetts Medical Society, among other work that she's involved with. Our second panelist is Chloe Schwartz, and she is an MPH in Director of Maternal and Infant Health for the Massachusetts market of the March of Dimes. In this role, Chloe is responsible for designing and implementing the strategic plan for the market level, including both programmatic and advocacy agendas. Chloe has a master's in public health from Tufts University of Medicine and a BA in psychology from Boston University with an undergraduate certificate in criminal justice. She is working towards, well, she's already have her MPH, but Chloe, when she was in her MPH program, she did design and complete a research project for the Center for Reproductive Health under the U.S. Maternal and Infant Health Rights Initiative. The project provided a strategy as to how selecting birthing hospitals in New York City could better communicate patients' rights before and during childbirth. And our next panelist is Dr. Grace Lubwama. And Dr. Grace Lubwama is the CEO at the, let me just grab my notes here. Okay, so Dr. Grace Lubwama is the CEO at the Kalamazoo YWCA of Central Massachusetts, located in Michigan. As a native of Uganda, she's brought her broad global perspective, experience with public health, organizational leadership, and community development to the YWCA Kalamazoo. Her perspective infuses her strong systems change approach to issues of social justice and community transformation. Since Dr. Lubwama arrival to YWCA Kalamazoo in 2014, her leadership has placed the organization in the forefront of the Kalamazoo community. Dr. Lubwama experiences hold the organization mission in infidelity as it addresses domestic violence, sexual assault, and human trafficking through a racial and gender lens. Understand the importance of targeted interventions for the most vulnerable. Under Dr. Lubwama's leadership, the YWCA Kalamazoo opened the first shelter for all victims of human trafficking in the state of Michigan. She is not one to shy from controversial work. She's used her experiences to help Kalamazoo community-based organization and healthcare system found the Cradle Kalamazoo, a collective impact framework designed to address the racial disparities in Kalamazoo County's infant mortality rates. Dr. Lubwama received her BA in Fine Arts and Industrial Design from Makerere University in Kampala, Uganda, and her MPH from Boston University, and her PhD in Policy Planning and Development from the University of Southern California. And for our last panelist, who is going to be on mainly during our Q&A, is Dr. Claudia Pierre, and she is also an MD in an OB fellowship trained family medicine physician practicing full spectrum family medicine, including maternal care, and that includes performing C-sections. She works at the Family Health Center of Worcester and is the leader of prenatal services there. She provides maternal care to UMass Memorial and is a part of the UMass Memorial Maternal Anti-Racism Task Force. And she is also a faculty member at UMass residency program, as well as an assistant professor at UMass Medical School, and where she teaches family medicine residents as well as medical students. And she is part of several UMass anti-racism, oppression, diversity, and inclusion groups. And without further ado, I would love to welcome our first panelist, and that is Dr. Sara Shields. Thank you.
Good morning. I hope you can see my slides okay. And thank you so much for this invitation to talk to you a little bit about the work that I've been part of in Worcester around reducing the disparities in infant mortality. So I'm going to share, see if I can remember how to go forward on the slides. There we go. So I've been part of the Worcester Healthy Baby Collaborative for a number of years. We are a diverse coalition of community groups and public health and healthcare providers. We've been meeting since the early 1990s to try to look at why Worcester's babies die more in their first year of life than elsewhere in the state, and particularly, at least initially in our work, for Black babies to die at a higher rate than white babies. I'm going to go through some of the partnerships we have as I go through my talk, but we've always had an unwavering commitment to address health equity and seeing infant mortality as really a part of multiple social determinants such as poverty and education, but also racism in all of its forms. And we've always wanted to be part of looking at that. So we're glad to share our work today in this forum. And sorry, get my so before we start, I do always like to take a moment to pause and just have a moment of silence together to think about the families who suffered through either infant death or maternal death. Nationally in 2020, 861 women lost their lives in relation to pregnancy or the year after pregnancy. In infant deaths in 2018 were about 21,000 families nationally. In Massachusetts, we have data of about 12 maternal deaths a year and about 260 infant deaths. So just to pause for a minute to hold these families in our thoughts, because it's a tragedy for all of us that these deaths occur, particularly when so many are preventable, and these deaths have repercussions across generations and through communities. So thank you for a moment of silence. So as we talk about infant death, I just want to make sure we have the same definition because the numbers we're going to talk about, sometimes people mistake them for percentages. And I always say if we were actually facing 5 to 10% of babies dying before their first year of life, we should all quit our day jobs and work just on that. So when we talk about an infant mortality rate, it's the deaths in the first year of life divided by 1,000 live births. And nationally, the most recent provisional data from last year is that it's about 5.4 and there is about twice the rate of infant deaths for Black infants than for white infants in the state. That's about the same as well. Massachusetts usually has either the lowest infant mortality rate in the country or the second lowest. In 2019, which is our most recent year for data for the state, it was 3.73. But again, about double for Black infants than for white infants. So when we talk about infant health issues, they're usually driven by maternal health issues. So I think these two things overlap. And so particularly around the issue of prematurity, which is one of the main causes of infant mortality. So one of the things our group has been able to do is actually have real-time data analysis. And so we are able to do chart reviews and keep pretty up to date ahead of where the state is in the data. And so I'm presenting here the data that we've collected for almost the last 20 years. And we look at 3-year rolling averages. So that's what each point is showing. And I don't have to tell you the numbers for you to see that there's a discrepancy or a disparity here. So the orange line in the middle is Worcester's overall infant mortality rate. And we've been running roughly between 8 and 10 for sort of the late 90s and into the early 2000s, and have gone down now to our most recent number is about 4.8, although that ticked up a little in that last 3-year period that we have data for. And then the gray is the Hispanic infant mortality, which is higher than the white. And you can see that in the mid-2000s, we saw a huge spike in Hispanic infant mortality. And that was not happening either at the state level or the national level for Hispanic babies. So something different was going on for Worcester with that. The darker blue line is the Black infant mortality rate in Worcester. And you can see this is why we were meeting in the 90s and early 2000s to try to look at this, because it was, 3 to 4 times the white infant mortality, if not more. So the other thing I want to mention is that infant mortality or maternal mortality is really only the tip of the iceberg around poor reproductive health outcomes. We really do want to think about morbidity or disease outcomes as well. We can talk about severe maternal morbidity or severe infant morbidity, things like women who experience severe preeclampsia or high blood pressure that has long-term, lifelong consequences for their heart health. But we can also talk about things like maternal mental health, maternal substance use disorder, and the access to treatment. And we're seeing in sort of the statewide Maternal Mortality Review Commission that I'm on, that those things are really an important piece of maternal morbidity and maternal mortality in the state. And then, I think with infant morbidity, a baby may be born prematurely and survive, but have a lot of sequelae or developmental delay and issues from that have lifelong consequences. And so we have to remember that to keep those issues in mind as well. We've been able to partner over the years with Worcester's different academic institutions, including Clark University, where some graduate students have worked with us in terms of this sort of geocoding, trying to look at census tracts and where infant mortality has these hot spots. So you can see the sort of traditional places where we think of the low income, the poverty, the lack of educational access in center of Worcester, perhaps up in the Great Brook Valley area. But what we've seen in the more recent analysis is some on areas on the outskirts of the city that have unusually high infant mortality, still among the Hispanic and Black mothers, but maybe the ones who are living in this sort of white dominant neighborhoods. So we're still trying to explore and think about those issues and the answers to why that. I'm sorry for my slide jumping ahead here. So the question is, what have we done about this over our 30 years of existence? So we've had a number of partnerships, including a federal grant called the Worcester Healthy Start Initiative, which involved case management for Worcester's most vulnerable families. And we did have a lower infant mortality rate for participants in that program. It wasn't a randomized trial, so it could have been that healthier people chose to be part of this program. But I still think that did help us with some of the issues we were facing. We held some focus groups about 15 years ago with African American women and African immigrant women in Worcester, who really talked to us clearly about their experiences of racism in Worcester's healthcare institutions, and mentioned some things like they wish Worcester had more physicians, nurses, and other healthcare providers of color. And so that's an ongoing issue we face. We started to do more community engagement work, really feeling like we needed to listen to what the community wanted from us. And that included a program called Nshira Ba, which means blessed baby in Twi, which is one of the common Ghanaian languages in Worcester. And so we did a lot of work where we tried to educate around healthy pregnancy behaviors, and the community came back to us and said, here's what we want you as clinicians to know, for instance, about the Ghanaian diet in pregnancy and how we can work together about that. We got a grant from the March of Dimes, who's been a partner of ours for more than a dozen years now, and did some neighborhood health fairs and developed these community quilts. We asked people who came to our table to fill out a quilt square, answering the question, what would you like to do for, how can you help a pregnant woman? And we put these together through some of our participants who were great quilters. And you can see one of these hanging at the City Hall if you get a chance to go there, and also at some of the places that that were the neighborhood health fairs sponsors. One of the things that came out of that March of Dimes grant was funds or the decision by the community that came to a community healthy baby forum that we held that chose the baby box project for us to pursue. So we've been giving out baby boxes, which are cardboard bassinets, as a safe place for babies to sleep, along with education about common newborn and parental health issues. And we're pivoting now to give out something else called cribettes, which are basically like pack and plays. And so we're calling ourselves the Safe Baby Project for that. We've been working for the last few years with the city's Department of Public Health to address breastfeeding resources for the Latinx community, and also to start the process of training the doula workforce. One of our partner agencies is Parnay Family Health Services, and with them, we've been working on promoting a pilot program to start again with newborn home visiting in Worcester. We've also held a series of infant mortality summits for several years, and the last 3 of those each year have included a place to invite people with lived experience of racism in maternity care or breastfeeding issues to come and speak. So we feel like that's been an important place of lifting up the voices of those with this experience. And I'll talk a little bit in a minute about the UMass Anti-Racism Task Force. I did put up here our QR code if you are so interested in donating to help us start purchasing the cribettes for both refugee families and other families in Worcester. I'll try to figure out how to put that in the chat later too. I do want to speak a little bit about the Family Health Center and our work there, because I've been there as a family doctor for a number of years. We have a very strong perinatal program that we're quite proud of. We have community health workers who are bilingual and bicultural and work as our case managers, and so much more for all of our pregnant families. All of these advocates are now formally trained as doulas, thanks to a grant that we got through UMass. And they're also the pillars of our group prenatal care program that we've been doing for 15 years in 4 different languages. And that has been shown to help with some of both the communication and empowerment pieces. We host the Baby Cafe, which is a breastfeeding support program, and are just about to expand to a Spanish language only version of that. And we are proud of being part of a program to do interconception care screening at all well child visits and use a family medicine model with a lot of behavioral health included in it. And then we also have a refugee clinic, which right now is doing a lot of service for both Haitian and Afghan refugees. You're going to hear a little bit from Dr. Pierre, I think, about our UMass Maternity Center Anti-Racism Task Force, which sponsored a summit last year to try to bring together some of the community voices. We're also really proud of the UMass Maternity Center's Teen Birth Program, which is trying to train all the physicians and nurses to really work on communication with laboring people and their partners. And we're seeing some preliminary results that suggest this program is really improving the experience of Black and Hispanic women and birthing people in labor around their feelings of empowerment and self-advocacy. So we're pretty excited about that as an important step in promoting some of the things we're talking about communication and all of that. So I'll stop here and let you move on to the next speaker and take questions when they come. Thanks.
Thank you. Thank you. That was actually really great timing, Dr. Shields. So for those who just joined, we're going to take questions towards the end. There are 3 questions that we have during our Q&A, and feel free to put any questions in the chat. And our second panelist is Chloe.
Okay, thank you so much. Just get my screen up here. Okay. Oh. Technical difficulties. Okay. Can everyone see that?
Perfect.
Great. So hi, everybody. My name is Chloe Schwartz. I am the Director of Maternal and Infant Health for the Massachusetts market of March of Dimes. I I am honored to be here to discuss the inequities that we're seeing in maternal and infant health here in our home state and share some of the work that March of Dimes does to help improve the health of all moms and babies. So mission work at March of Dimes can be boiled down to three main buckets: advocacy, mission investment programs, and research. So over the next few slides, I will provide some examples of the work that we've done and are continuing to do here in Massachusetts that fit within each of these categories. And before I get any further, I just want to mention that if anyone is interested in learning more about any of these initiatives, I will have my email up on the last slide should you like to reach out. So first, let's talk about advocacy and government affairs work that we are doing here on the state level. March of Dimes actively lobbies for a number of different bills and budget items during each legislative session, which means that we actively push for or against certain bills. Many of these bills that we are currently working towards fall within these categories here, ranging from midwives, doulas, Medicaid extension, postpartum depression, donor breast milk, and more. We will often send in letters of support and written testimony in favor of or in opposition to certain bills and line items. And for those bills that are more of a legislative priority for us, we may also provide in-person testimony. We may join or even lead coalitions. We'll meet with members of the legislature, and we'll even organize events around these bills. So we'll actually be holding this year's lobby day for March of Dimes here in Massachusetts on Monday, May 23rd, where members of the community can meet with their legislators to discuss March of Dimes priorities and their personal connections to them. So the link below, getinvolved.marchofdimes.org, will direct you to the sign-up page for our lobby day, as well as other volunteer opportunities around the country, including Massachusetts. So next is our mission investment programs, which are among our best tools to achieve direct local impact on a community level. Our three main program areas are NICU family support, supportive pregnancy care, and our training institute. Each of these programs are owned and operated by March of Dimes and have an in-person and digital format. So NICU family support helps more than 50,000 families each year in more than 65 hospital partner sites across the country, including one program that we have at Bay State Medical Center in Springfield, Massachusetts. Services of the program are built around three main areas: parent education, staff education, and improvement of the NICU experience for both the patient and the family. The program is coordinated by a staff member hired by the hospital who serves as a March of Dimes representative and liaison. Our NICU family support program actually just celebrated its 20th anniversary last year, and its inaugural program is actually still in place, which is very exciting. Supportive pregnancy care is our group prenatal education and care program, which can be implemented in a variety of healthcare sites that serve pregnant people, including OBGYN practices, birth centers, and hospitals. The program requires 2 healthcare professional facilitators, one of which must be a physician, midwife, or nurse practitioner, and it can accommodate groups of up to 12 patients. The curriculum is also customizable to the patient population, and in doing so, that helps to foster a sense of community throughout a patient's pregnancy and improve education and reduce stress. And as a trusted leader in maternal and infant health, March of Dimes has offered educational and training opportunities for healthcare professionals for more than 30 years. Through online and live training courses, March of Dimes provides peer-reviewed, clinically relevant content for providers that empowers skill building and new knowledge at the cutting edge of care. All training opportunities include CNE credits and often will include CME credits as well. So these trainings help drive a culture of change in the delivery of care for moms and babies to help reduce maternal and infant mortality and morbidity and to eliminate the health equity gap. In 2018, we launched the NICU Baby App, a free first-of-its-kind app supporting NICU families nationwide, and it is available in both English and Spanish. So whether you're a March of Dimes staff member, nurse, doctor, social worker, lactation consultant, or just a family friend, you can recommend this app to families, and we highly encourage anyone who is either currently experiencing time in the NICU or is anticipating time in the NICU to explore the use of this app. The NICU Baby App is for all families, regardless of their baby's length of stay in the NICU or their diagnosis. And the app has trusted information on how to navigate the NICU stay. Families can use the trackers on the app for feeding, pumping, weight gain, and kangaroo care to see their baby making progress in real time. And families can also use the photo booth feature to share photos of their baby. And there are also customizable checklists for getting ready to go home and for moms to follow up on postpartum care, because just because you're leaving the NICU doesn't mean the NICU experience is necessarily over. So finally, that brings us to research. March of Dimes provides a number of grant opportunities for maternal and infant health researchers across the country. And currently 3 of those March of Dimes funded studies are here in Massachusetts. One of these studies is being conducted by Dr. Mahalingea at Boston University, and she is evaluating the association between exposure to hair care products and its relationship to preterm birth. Also looking at the disparities between race and ethnicity in hair product use and birth outcomes. Furthermore, March of Dimes regularly partners with organizations across the country to help raise awareness of the work being done in the health equity space. So in January of this year, March of Dimes officially partnered with Power Mom, which is a smartphone app-based research study out of Scripps Research that enables expectant mothers-to-be to share data about their pregnancies in real time with scientists. Additionally, the data will be viewable to patients in real time, which allows them to access health information and comparative insights throughout their pregnancy. This growing database of pregnancy-related health information powers research into the unique factors that impact maternal health outcomes. The goal of this study is to help achieve health equity in maternity care for all pregnant people, and is doing so by actively involving pregnant people from diverse communities throughout the US. Currently, there are more than 4,500 pregnant individuals signed up for this study, and you can download the study on iOS or Android in the App Store. It is called My Data Helps, and then you input the code PWRMOM. So that is just a brief overview of some of the work that we do here at the March of Dimes to help close the health equity gap for moms and babies. And I would also like to mention that we are a proud member of the Worcester Healthy Baby Collaborative that Dr. Sara Shields chairs. So thank you so much all for your time. And please don't hesitate to reach out if any of these programs are of interest to you and you would like to learn more, as you know, those were somewhat of a brief overview of them. But I will hand it back over to Gemma now.
Thank you, Chloe. And if we have any new people here in our audience, I just want to mention that this is a forum to address the disparities that Black mothers and their infant face. And we do have panelists, about 4 panelists on this forum today, and each of them are presenting about information on this topic. Please feel free to ask questions in the Q&A chat, and all of those questions will be discussed when we have 10 minutes during our Q&A session. And we do have our last panelist, and that is Dr. Grace Lubwama. She's the CEO at the YWCA Kalamazoo in Michigan.
Hi, Jermoh. Thank you so much for having me. And Dr. Shields and Cleo, thank you so much for the information that you're giving. I was sitting here as you're giving a presentation. I was like, oh my God, that's my part. That's my part. So I'm going to have to pivot and really talk about the work that we're doing here at the YWCA Kalamazoo. And we sit in a space, Brianna, if you could go to the next slide. We sit in the space where we've been having this conversation for a long time. It's unfortunate that the data we speak about in different parts of the country, it is the same. It is the same. We're talking about the same disparities. The numbers may look different, but when you talk about the disparity gaps that exist between families of color and white families, women of color and infant, the disparities, like the story and narrative is the same. I hope we get to a point where we close those disparities. Dr. Shields has said infant mortality, when we talk about infant mortality, we're really talking about the well-being of a family, the well-being of a community. How well is our local communities taking care of their babies, taking care of their mothers? And unfortunately, around the country, we have failed. We have failed to take care of our children. We have failed to take care, especially our Black children. And until we do intentional work, because we can speak about this, every day from day to day, we could do more surveys, we could collect more data. The data is going to come back to the same place. But until there is intentionality of how we close the gaps. And the work we do at the YWCA Kalamazoo comes from a really community-based perspective, where we are very intentional with involving the mothers, with involving mothers that have had previous birth outcomes or have had loss in their families. And the disparities, like I said, Brianna, go to the next slide. The disparities are the same. In Kalamazoo, which is a really beautiful, I call it the beautiful oasis of Michigan, because I've lived in Boston and Los Angeles and then to Kalamazoo. I had never heard of Kalamazoo until I came. And unfortunately, in 2014, we had the same story, like around the country. In the state of Michigan, our beautiful Kalamazoo had one of the highest infant mortality disparities amongst our Black babies. And it was unfortunate. And we mapped it out in our local communities to see, where is this really happening? The narrative was same. We're a small segregated community, and we knew where you see the red, that's where most of our Black families live. That's where most of our families of color. So, from a logic perspective, we were going to see the same answers that we were looking for. So those disparities really existed highly in our communities of color, in our communities of Black families. Brianna, go to the next slide. So in 2000, and in our own community, we had been talking about this for years. And in 2014, we wanted to do some intentionality. Are we there yet? We are not there, but we are working to get there. And it's unfortunate, in our community, income was not even a protector for Black women. So wealthy, educated Black women, income, education was not even a protector for those families. And we knew that the disparities were really rooted in systematic racism on how do Black women, how do Black families interface with any structures within our community. And now in public health, we talk about the social determinants of health and how, touching those families with those different elements. So in our own community, poor white women had better birth outcomes than Black women who were wealthy, who were educated. And once we saw those gaps, the conversation around racism and systematic racism in our community became real, because none of these things were protectors for these families. So that means we had to have interventions that could dismantle systematic racism, and interventions that were not just Band-Aid. Within the public health work, we have all the community outreach workers framework. We have the framework to do the work, but I think what we haven't had is really the intentionality to shift those numbers to the positive direction. Brianna, if you go to the next slide. So, I have been so fascinated about the James Hickman research that he's done about, investment and financial investment. We're gonna go to the next slide. And I started to push our own community in Kalamazoo. Research has been very, very clear. We have to invest in prenatal programs. That is where our highest investment should be. In our own community, we had an anonymous donor that gave a donation to the Kalamazoo. For every child that goes to Kalamazoo Public School, they have an opportunity to go to either college or community college, higher education for free. And that was a big investment for our community, which was really good. So then we started to find out after 10 years that even with that investment, children, especially Black children, were not even ready to graduate. They were not even ready to go to college. We needed to shift back and do more investing once a child is born, once a Black child is born. And research has been very, very clear. When we invest in prenatal services, our highest dollars, we're going to get the highest return on investment. That means we'll cover all those things, preschool, schooling, job training. I challenge people when we get to the high level and they're trying to find people of color, they're trying to find Black individuals to join boards, to be at the clinics as physicians. The numbers are very clear. They're not there. And I tell people they probably died before they could even get an opportunity to do this work. So there has to be an intentionality, an investment in our community for us to get the right results. We will not get a diverse workforce if we are not investing in prenatal services, if we are not investing in the birth of Black children once they come into our own community. Next slide, Brianna. So, some of the work, once we really started to understand the social determinants of health, and again, from a public health framework, we've been talking about this. We became committed at the YWCA in Kalamazoo that we needed to look at the different elements, the key elements of families as we engaged with families in our own community. Looking at, when a family faces the healthcare system, what are those things in place? Are we really intentionally looking at their neighborhoods and what's happening within their own neighborhoods? Economic stability. We've just started a fund, which is one of the first in the country, where we're providing financial support for reproductive health work so that we support the reproductive health justice. The social context, really having an intentional conversation in our own community, whether it's with the criminal justice system, with the healthcare system, with all the system of where is your racial justice lens? How do you face when you go into a Black community? What are you doing different? And then, education access and quality. We are fortunate we have the Kalamazoo Promise. So there's been intentionality, some of the things that we are trying to do in our own community with the end goal of promoting maternal and child health, knowing that if we touch all the different elements of the social determinants of health, we will eventually get there. Brianna, go to the next slide. So within our work at the YWCA, our mission is very clear: eliminating racism and empowering women. That's the mission for all the YWCAs around the country. And that speaks to, I am born and raised in Uganda, so I'm an African. And in our culture, we know that even if you don't have a biological child, every child of the village belongs to you. You don't have to be their biological mother. And we've also learned that every time you empower women within the community, the rest of the community, the rest of the village will be empowered, whether it's non-conforming individuals, the rest of the village will be empowered. So we stood in that space with a mission of eliminating racism and empowering women at the center of race and gender equity. We designed a strategic focus area for the YWCA in Kalamazoo. And we said, we are going to focus on 4 areas in the work that we do. Improving the lives of children. You will not empower women. You will not empower individuals if the children are not empowered. So we opened a child care center to support families, provide child care. Last year, we opened the first comprehensive 24-hour child care center in the state of Michigan. That means you can drop off, which has the traditional child care services, but also you can drop off your children anytime. If you have a doctor's appointment, if you need to go to court, you can drop off your children at the YWCA Child Care Center. We also provide third and second shift. Then we work through advocacy and system change. We're at the state level. Right now we are part of a ballot initiative that is really pushing reproductive health services in our state. Reproductive health justice, around Medicare, how we can increase access for women. So we have been in that space for a long time, doing a lot of advocacy at the state level and also at the local level in our own county, where we did increase, again, a reproductive health fund that increases access for abortion services, transportation, gender conforming support. So we do a lot of work around that space. And then we also do domestic violence, sexual assault, and human trafficking work. So in the space of caring for victims of abuse, and we know just in our own domestic violence shelter, 80% of women that come to us when they are coming from abusive relationships are usually pregnant or have children. And we know research has shown us that abuse escalates during child giving birth ages. So we have a shelter that supports individuals who are going through abuse. And then we recently added promoting maternal and child health, and that's the program I quickly want to speak about. that is intentional on following Black women in our community with a community health work model where we go in to support them and follow their children for 5 years and then connect them to a child care center. So Brianna, if you go to the next slide. So that's a strategic focus area within the work. What we are trying to do is really fit our work in those strategic areas that when we meet a family from the time of pregnancy, we know we've provided improving children of lives, we provide childcare services, we are touching things around dynamics of abuse. When we did a survey in Kalamazoo, we found out that abuse was one of the indicators of infant mortality in our own community. So we've lined our strategic focus areas to really support the work that we're doing in our own community. Next slide. So again, part of the work that we have done is really centering the client voices and engagement in everything that we do. We do client panels all the time where we go back, we partner with the medical school here that does the evaluation component of the work that we do. We do a lot of going back and asking the women who have experienced birth outcomes in our own community, mystery shopping, where we send in, women of color, Black women into our healthcare system, into our school, and ask them what the experience is, because we know in our own community, income, education, none of those are protective factors. And once we do those, we come back and give, the institutions, recommendation and speak to the experiences, especially Black women and Black individuals and families of color experiencing in our own community. But we are really driven of our strategy by the client voice and engagement and making sure that we are addressing the gaps and making impact. We have moved from an agency that is just doing good work. So we are always pivoting to have real impact and then really doing our work through a race and gender equity lens. Brianna, next slide. Go to the next slide because I think I've talked about that work. Yeah, I wanted also to talk about some of the things, and I've already said the way we're engaging in our work through engagement, outreach, definitely direct service and advocacy and system change. Using an example of the mystery shoppers that we've put out in the community to do those things. So we are really surrounding our work in that space. Next slide. So I'll give a high level program view of what we do here at the YWCA with our WISH program. And we also lead the community collective, which is called Cradle Kalamazoo. This is an infant mortality initiative in Kalamazoo that has more than 24 agencies that is focused on addressing the racial disparities that exist in our community. So the YWCA takes a space in that space. In that initiative, we have home visitation programs that exist in our community. We have Healthy Start, we have March of Dimes, we have all these other agencies that are similar in the community that you have. So what we did a landscaping and analysis and say, okay, where are the gaps? We have Healthy Start. For us, it was just particular to some zip codes. We said, where are the gaps that are happening? So we created a program through this collaborative at the YWCA that was really meeting the needs of the community and covering the gaps that other programs were not meeting. So it's a community health workers model that is focused on Black women. It doesn't matter whether you have income or no income. You, as a Black woman who identifies as a Black woman, you're part of that program. Any women of color, any women that have had previous birth outcomes are also followed in our program. And we're doing a very traditional, community health worker model where we go in and assess and understanding that my needs are different from Chloe's needs. Chloe's needs are different from Sarah's needs. So we go in a model of assessing, how can I help you? How can we do the work? So I'm probably gonna stop at this, but my slides give you a high level of the work that we do. So the WISH program is really embedded in the community health work model, which is evidence-based, and that's how we support the families. I will stop there and be quiet.
What a wonderful presentation. All of the panelists, such great information. Thank you so much for the different pieces in which you've all laid out here, looking at maternal and infant mortality rates here in Worcester, looking at the policy level with what March of Dimes is doing here in Massachusetts, and then also looking at the same topic, maternal and infant mortality, and strategies at the level of Kalamazoo, and also, you know, and how the YWCA in Kalamazoo is actually targeting this. So thank you so much. We have about less than 10 minutes left, and I just want to open this up for some Q&A. I know there are, you know, a few questions in the Q&A in the chat room right now, so I think we probably might be able to only take like 2 of them. And Dr. Shields and all the panelists here, and Dr. Pierre and Dr. Grace Lubwama and Chloe, please feel free to, if there's any questions that I don't get to, please feel free to type, you know, the answers in there if it's directed to you. And at this junction, I would like to ask one of the questions. One of the questions that came up is from an anonymous attendee, and the question is, is there any work being done around home birthing and midwifery? No protections for families around practitioners that have had negative outcomes. There's no record of this anywhere. I lost a grandson at the hands of the only Black midwife in Massachusetts. There is no resource for my son and his partner. Are there any groups that may be available to connect that are doing work around legislation of midwifery in Massachusetts?
So I will say that I am aware of 2 pieces of legislation here in Massachusetts that are around midwifery, and I do believe one of them touches on home birth midwifery specifically. I will say that all of the bills that March of Dimes supports as it relates to midwifery, we typically constrain our support to certain licensures of midwifery, and currently in Massachusetts, there is only one licensure recognized by the state, and that's certified nurse midwife. And so each of the bills that we would support would improve the licensure process and registry systems for midwives, so that, you know, as like any other healthcare professional, everyone can be held accountable, and also maintain, you know, registries of who is actively practicing in the state. But as far as recourse, I'm not aware of who might be the most appropriate contact for that. But hopefully that provides a little bit more clarity.
Thank you. Does anyone of the panelists want to tackle that? If not, I will move on to another question. Thank you. So one of the questions that that I had in terms of just looking at specific things that, and this is, we'll probably go back to Chloe. I know that I have gotten some questions in terms of what is March of Dimes actually doing as far as it relates to research or policy work, specifically around Black mothers and infants.
Sorry, can you repeat that?
So is there any like work that is being done at the level of March and Dimes that targets policy or even like trainings with physicians or healthcare workers here locally that ties into reducing the mortality rates among Black women and infants?
Yes, so the most clear example I can provide is our implicit bias training, which is called Awareness to Action. And that is a training that can be implemented at healthcare sites and is specific to maternal and infant health, although it can be amended for all healthcare professionals. And it is also provided to anyone who is patient-facing in those healthcare sites, so including administrative staff. And one of the things that I think stands out in our March of Dimes specific training is that it not only introduces maybe perhaps new concepts within the realm of implicit bias, but it also provides a toolkit as to how to actually take that information and do something with it, hence the name Awareness to Action. And there is an add-on session that leadership within those healthcare sites can partake in that will take post-evaluative surveys of the participants from that training session and turn that into tangible change. They'll take the information that participants said as far as, you know, what they would like to do to change their behavior, but what is preventing them from changing their behavior, what did they learn, what is sticking with them, and actually take that information and make real change. On the policy front, you know, all of the policies that we support have an equity lens to them. So for example, you know, extending Medicaid, I believe in Massachusetts, the largest proportion of Medicaid recipients are women of color. So by extending Medicaid, we can expand equity, health equity in that sense. So any policy that we take on does have an equity lens.
Thank you. And this presentation has been recorded, so participants who have had the time to be here can access that on the YWCA's website and website, or what I'm talking about, social media platforms. And I also want to mention that please, you know, do share this with your networks once it's up. And we're now almost about time. There have been some answered questions from our participants in the chat. So so that was another way in which members could ask questions, and then folks, some of the, you know, the panelists will answer that. And so at this junction, I want to thank every panelist that had the opportunity to join us here to provide such wonderful, informative, in-depth information. Dr. Shields, Dr. Pierre, Chloe, and then Dr. Lubwama. I also want to thank you know, my CEO here at the YWCA of Central Massachusetts, Dr. Deborah Hall, Craig, who is on our who is our DV staff, domestic violence staff here at the YWCA on the technology, Gina, who is our marketing, and then Maritza, our racial and gender equity director, and of course, all the folks here at the YWCA that has joined, and every participant here that has joined us. We want to thank you, and we do ask that you share this information and look out for any work that the YWCA Central Massachusetts will be doing around this issue. We might have a part 2 of this. Stay tuned, and thank you again. And I hope that you have a great rest of your day. And if you do need the presentation, though, we will email it out to you. Inquire that, and we will email out the presentations from our participants, from our panelists here. If you want specific questions, and you can contact us at the YWCA of Central Massachusetts, or I would just put my we can just put our emails, Gina, or I can put my email there. We will give out the presentations for those who may want to have this for themselves. Thank you, everybody.